So let's talk about the otitis media. So what is otitis media? So it is infection of middle ear. Infection of middle ear is otitis media. So now it can be acute otitis media or chronic otitis media. If the duration is less, so it is acute, and if duration is more, that is chronic. Okay. So how does it happen? How does the infection in middle ear? So obviously there is a ET tube, eustachian tube, which is connecting middle ear to pharynx. So mostly it is due to pharyngitis. So if there is an infection in pharynx, so infection from pharynx can go from the ET tube, eustachian tube, from pharynx to middle ear, and that can lead to infection in middle ear. So most common organism is virus. In case of bacteria, it is Streptococcus pneumoniae. So in acute otitis media, there is various stages. Obviously, if there is infection from ET tube, so there is ET tube obstruction. Then stage of hyperemia. Hyperemia. So you will find in tympanic membrane there is a cartwheel appearance. There is a cartwheel appearance. So if there is a cartwheel appearance, that is stage 2 of otitis media. Stage 3 is stage of suppuration. Pulsatile otorrhea, that is lighthouse sign. Okay. So you will find pulsatile otorrhea. What is pulsatile otorrhea? So pulsatile otorrhea is nothing. It is ear discharge synchronous with pulse. Okay. So that is pulsatile otorrhea, lighthouse sign. Okay. So how will you manage this condition of acute otitis media? That is by giving the antibiotics and decongestant. Okay. If the infection does not resolve by the antibiotics and decongestant, you have to do myringotomy. What is myringotomy? You have to make a incision in tympanic membrane. You have to make an incision in tympanic membrane, which releases the entire fluid. That is myringotomy. That is for drainage of pus. Okay. And one thing what you have to remember. So myringotomy is done for the drainage of sinus, and you have to understand incision is given in the posterior inferior quadrant, because in posterior superior quadrant there are vital structures. So you have to avoid the vital structures. So you will give the incision in posterior inferior quadrant. So this is acute otitis media. You have to give curvilinear incision. Now, acute necrotizing otitis media. So it is due to beta hemolytic streptococci. Perforation will be marginal and eroded. It predispose epithelium from external auditory canal to middle ear, which form the cholesteatoma. Okay. Now the type of perforation. So central perforation. So if there are perforation of pars tensa, if it is not involving the annulus, so there are 4 types: anterior, posterior, inferior, and subtotal. Marginal is involving the annulus. So this is different type, and this involves the annulus, that is marginal. Okay. Now the serous otitis media, it is because of non-infective obstruction of ET tube. Obstruction of ET tube is because of adenoid hypertrophy, nasopharyngeal carcinoma. In both these conditions, there is obstruction of ET tube, and obstruction of ET tube will leads to hearing loss. Okay. Patient will present with retracted tympanic membrane. Patient will have prominent lateral process, shortening of handle of malleus. Okay. So these all are the features you will find in serous otitis media. Okay. You will treat surgically adenectomy, myringotomy, and grommet insertion. So by adenectomy, you have removed the cause. Because of adenoid hypertrophy, it leads to serous otitis media. So you have removed the cause, that is adenectomy. Now you are treating the condition by doing the myringotomy. So what is myringotomy? This is tympanic membrane, and you have you have created a hole, so that is known as myringotomy. And grommet insertion, so you have put a pipe in it, that is grommet, which leads to drainage of pus, drainage of fluid. So that is serous otitis media. Okay. So myringotomy in ASOM, you have to do posterior-inferior. In serous otitis media, you have to do antero-inferior. Curvilinear incision in ASOM. In serous otitis media, it is radial incision. In serous otitis media, you have to insert a grommet. Okay. In ASOM, there is no any grommet insertion. Okay. Now CSOM, chronic otitis media, it is of 2 types: chronic mucosal otitis media and chronic suppurative otitis media. So chronic mucosal otitis media, it is because of central perforation in pars tensa. If it is marginal perforation, then it is due to chronic suppurative otitis media. Are you getting my point? Pars tensa, perforation in pars tensa is good, is better than the perforation in annulus, because pars tensa can heal. So it is chronic mucosal otitis media. It is known as safe here. Okay. And in case of marginal perforation, it is chronic suppurative otitis media. It is unsafe here. Okay. So chronic otitis media, it is permanent in the central pars tensa. It is tubotympanic. It is also known as CMOM, that is chronic mucosal otitis media, or tubotympanic chronic suppurative otitis media. Now patient will present with mucopurulent discharge, painless, perfuse, mucoid discharge, because it is from the middle ear, so it is mucoid discharge. Okay, 10 to 40 decibel hearing loss because of ossicular necrosis, lenticular process of incus, then long process of incus, treatment by myringoplasty, ossiculoplasty, that is known as tympanoplasty. Okay, graft to give this to cover the pars tensa, we have to put the graft, that is temporalis fascia. Okay, round window shielding effect. So round window is covered by the discharge, so that is round window shielding effect. So it is protected there by maintaining the phase difference, better hearing in the discharging ear. That is round window shielding effect. Okay, various type of myringoplasty is there, overlay and underlay. So I am not going in detail of all these. These are the type of myringoplasty: type 1, type 2, type 3 over the stapes, type 4 and type 5. Okay, so these are the various type of tympanoplasty, myringoplasty. Okay, that is Bulstein classification. Now the CSOM, that is unsafe here. It is because it is also known as eticoenteral chronic otitis media because of marginal perforation. So presence of keratinized stratified aqueous epithelium in middle ear or mastoid is cholesteatoma. There are various types: congenital, acquired, primary, secondary. Congenital is presence of congenital, it is presence of keratinized squamous epithelium. Okay, acquired epithelium migrate from the external auditory canal. Now two types, primary and secondary. So if the cholesteatoma is not present secondary, so that is primary, and secondary because of marginal perforation. I have already explained to you marginal perforation in tympanic membrane. Okay, there are various theories for cholesteatoma: Whitmack theory, Reduce theory, and SAD theory. Okay, now the clinical features. So obvious, you have to understand in case of chronic otitis media, chronic mucosal otitis media, that is profuse discharge. In case of chronic suppurative otitis media, there is scanty, foul-smelling discharge, painless, bony erosion is there, hearing loss, and it can only be managed by surgical. There are two types of surgery: canal wall down surgery, canal intact surgery. So canal wall down surgery is there is a connection between external auditory canal and mastoid. So that is canal. If you remove that canal, then that is canal wall down surgery. That is MRM, modified radical mastectomy, radical mastectomy. It is done for extensive disease. Okay, in this case, chorda tympani is sacrificed. In case of intact wall, if this is mastoid, this is externally middle ear. So if there is an intact canal wall, this is intact canal wall. So in this case, there is repeated infection in intact canal wall. Okay, it is by combined approach by canaloplasty for limited disease. Now what are the complication of otitis media? There are various complications. So in case of ASOM, that is acute mastoiditis, because of Streptococcus pneumoniae, reservoir sign, pus keeps refilling the middle ear after cleaning, that is reservoir sign. You will find the sagging posterior wall, pinna pushed outward and forward. Okay, these are the reservoir sign. You have to do mastectomy in this case because mastoid is present near to the middle ear, so it is most commonly affected. It is mastectomy. In case of mastectomy, pus rupture and extend, so it can extend to the superior. You can the pus can goes anywhere. So if it is goes superior, that is zygomatic abscess. If along the sternocleidomastoid, that is resolved abscess. Along the posterior valley of digastric, that is Citylis abscess. So these are the different type of abscess. Okay, if it connect to the petrous apex, that is petrositis. Now the Gradinego triad, that is uh, retroorbital pain, paresthesia over face, and the sixth nerve palsy, diplopia, persistence, ear discharge. So these all are the features of Gradinego triad. Okay. Now the intracranial complication, extradural abscess, subdural abscess, and temporal lobe abscess. So these are the intracranial complication. Meningitis, most common complication, sigmoid sinus. So it involves the sigmoid sinus thrombosis, temporal lobe abscess. So are you getting my point? Infection from middle ear, chronic suppurative otitis media from the middle ear can go superior, can go anterior, can go inferior, can go posterior. So it can go anywhere. So that is known. So that's why it is very dangerous, chronic suppurative otitis media. Okay. And it can cause a temporal lobe abscess, IgB thrombosis, otic hydrocephalus. What is otic hydrocephalus? It is non-infective embolus from the sinus thrombus lodged in the another vein. Okay. So this is otitis, entire otitis media. Okay.